Good morning. Today's topic is on epidemiology of oral cancer. Learning outcomes. At the end of the topic, the student should be able to explain the public health concern of oral cancer, analyze the role of risk factors in oral cancer, plan preventive strategies for control of oral cancer at individual and community level. Introduction. Cancer. You can see here a crab. A Greek word karkinos meaning a crab. The word cancer means crab, thus reflecting the true character of cancer. It sticks to the part of stubbornly like a crab. Definitions. Cancer is defined as an abnormal, excessive, unwanted, uncontrolled and uncoordinated growth of cells which continue to proliferate even after the removal of causative stimulus. Problem statement of cancer. Cancer affects all communities worldwide. Approximately 10 million people diagnosed as cancer per year. 6 million people die of cancer per year. 22.4 million people survive with the cancer per year. In Southeast Asia, cancer accounts for significant proportion of morbidity and mortality. It is estimated that about half a million people die every year for cancer. Cancer attributes or contributes to 3.4% of all deaths reported from India, 6.6 from Indonesia, 2.9 from Myanmar, 0.8 from Nepal, so on. Coming to different types of lesions, in that pre-malignant lesions. It is defined as morphologically altered tissue in which cancer is most likely to develop than in its apparently normal counterpart. Example, leukoplakia and erythroplakia. Premalignant condition is a generalized state associated with the significant increased risk of cancer. Example, oral submucous fibrosis and lichen planus. Classification of cancer. Cancer are classified by the type of cell that the tumor resembles and is therefore presumed to be the origin of the tumor. Carcinoma, cancer derived from epithelial cell. Example, basal cell carcinoma, squamous cell carcinoma. That's epithelial cell carcinoma. Sarcoma, cancer derived from connective tissue and mesenchymal cells. That is Kaposi sarcoma and liposarcoma. Lymphoma and leukemia, cancer derived from hemopoietic cells, that is blood forming cells. Germ cell tumor, cancer derived from pluripotent cells. Blastoma, cancer derived from immature precursor of embryonic tissue. These are also commonest in children. Categories of oral cancer. On the basis of the site of occurrence, oral cancer can be classified as cancer of lip, cancer of labial mucosa, cancer of labial commissures, buccal mucosa, floor of the mouth, tongue, palate, palatine arch, gingiva and alveolar ridge. According to the tissue of origin, for example, epithelial tissue of origin, that are basal cell carcinoma, squamous cell carcinoma, varicose carcinoma, then adenoid squamous cell carcinoma. Connective tissue origin, fibrosarcoma, malignant fibrous histiocytoma, liposarcoma, Kaposi sarcoma, and others. Muscle origin, leiomyosarcoma, rhabdomyosarcoma, alveolar soft part sarcoma. The nerve tissue, malignant neurilemoma. Precancerous lesions in oral cavity. They are leukoplakia, erythroplakia, stomatitis nicotina palate, median rhomboid glossitis, palatal erythemas. Precancerous condition. OSMF, lichen planus, xeroderma pigmentosa, lupus erythematous, leukoedema. Malignant tumors of oral cavity. That's basal cell carcinoma, epidermoid carcinoma, carcinoma of leaf, etc. Epidemiology of oral cancer. Oral cancer is more commonly seen in developing than developed countries. Being the eighth most common cancer worldwide, the prevalence of oral cancer is particularly high among men. Incidence rates of oral cancer vary in men from 1 to 10 cases per 100,000 population in many countries. In South Central Asia, cancer of the oral cavity ranks among three most common types of cancer. Oral cancer trend in Malaysia. Recognized in 1960, prevalence was 0.04%. Higher frequency found among indigenous group of Sabah and Sarawak. In Malaysia, the National Cancer Registry, that is NCR, reported that for year 2003-2005, oral cancer is ranked 22nd and 15th most common cancer among males and females in peninsular Malaysia. Coming to epidemiological triad, as we discussed in general epidemiology, there are three factors like host, then agent, then environment. All together, when intersect, that is leads to disease. Coming to the host factor for cancer. First is age. The observation that oral cancer generally occurs with advancing age indicates that over the time, certain sequenced alteration in biophysical process, that's nuclear, enzymatic, metabolic, of aging cells with a particular genetic predisposition undergo and accumulate mutation resulting in carcinogenic transformation. Approximately 90% of all oral cancer is diagnosed in persons older than 40 years and more than 50% of all cancers occurs in person aged over 65 years. Gender. In the industrialized countries, men are affected almost twice as often as women, probably due to their higher indulgence in risk factors such as alcohol and tobacco consumption for intraoral cancer and sunlight for lip cancer. The ratio of males to females diagnosed with oral cancer is 2:1 over lifetime, although the ratio comes closer with 1:1 with advancing age. Race or ethnicity. All races like 15.7 per 100,000 men are females, 6.2 per 100,000 women. So if you see white, black, Asia Pacific, American, Hispanic, the prevalence of oral cancer is more among the males compared to the females. Customs and habits. Smoking and alcohol consumption in some cultures are culturally accepted. Even females consume tobacco and alcohol as frequently as males. These people are at high risk for oral cancer. Socioeconomic status. The prevalence of oral cancer is higher among the lower socioeconomic group compared to the upper socioeconomic group. May be attributed to the lower nutrition status of this population. Occupation. Certain occupation where exposure to carcinogens is common like tar manufacturing, then certain oil textile industries are susceptible to cancer. Leather workers are shown to have higher rate of cancer of buccal cavity. Loss of teeth. It is reported that edentulousness may indicate a greater risk for cancer of oral cavity. According to the study by Blott et al., edentullousness is predisposing factor for the oral cancer. Systemic diseases. Immunosuppressed individuals have higher risk of oral cancer, that is, the people who are suffering from hepatitis and diabetes. The molecular basis for the putative association of diabetes mellitus with oral squamous cell carcinoma from epidemiological studies may involve insulin receptor substrate 1 and focal adhesion kinase. Hormones. Estrogen may be increase the movement of precancerous cells in mouth and promote the spread of head and neck cancer, report a US study in cancer prevention research. Blood group. Association of blood group with oral cancer has also been observed. It has been reported that group O showed the least susceptibility, that is blood group O. Then the blood group B and AB showed a doubtful susceptibility, and blood group A showed higher susceptibility. Floor of mouth, inside lining of the cheeks, gums, roof of mouth and lower lip. Agent factors. First is physical, that is ultraviolet radiation. This is a risk factor for skin cancer of the face and other exposed areas, particularly in fair skinned individuals. It is also important in the etiology of squamous cell carcinoma of the vermilion border of the lip, especially in those who work outdoors. Ionizing radiation consists of particles or electromagnetic waves that are energetic enough to detach electrons from atoms or molecules, therefore ionizing them. Alpha, beta, gamma rays, neutrons, protons, neutrinos, muons and pions. These are some of the ionizing radiation which might cause cancer. Mechanical factors like chronic irritation, friction and trauma. People with poor dental health, such as sharp, broken teeth, and dental sepsis, trauma from ill fitting denture, are at a slightly higher risk of developing oral cancer. Biological factors like viruses. Infection with human herpes virus 1 may also increase the risk of oral cancer, but the available data are not conclusive. Diet and nutrition. Several components of diet are seen as tumor promoters or anti-promoters. They may enhance or impede the delivery of carcinogen or alter the susceptibility of the target tissue to the carcinogen. Alcohol. Alcohol is an independent risk factor for oral cancer. A synergistic effect of all tobacco and alcohol has been observed. They account for 75% of all oral and pharyngeal cancers and have been implicated in the formation of multiple primary cancer sites found in oropharyngeal cancer patients. Then comes the free radicals. Free radicals such as reactive oxygen species and reactive nitrogen species can function both as initiators and promoters in carcinogenesis, while antioxidants provide protection against the cellular and molecular damage caused by reactive oxygen species and reactive nitrogen species. Chemical factors, that is tobacco, is an agricultural product processed from the leaves of plants in the genus Nicotiana of the potato family. It can be consumed used as an organic pesticide and in the form of nicotinic tartrate used in some medicines. It is most commonly used as recreational drug and is valuable cash crop for the countries such as Cuba, China and United States. These are the forms of tobacco. These are the forms of tobacco which is in smokeless form. Public health issues. It is evident from the results of Global Adult Tobacco Survey, that is GATS, that tobacco consumption is still major public health problem in Malaysia. About a quarter of Malaysians smoke tobacco, that is 43.9% of men and 1.0% of women. In addition, a daily cigarette smoker smokes an average 14 cigarettes per day. That's huge. In Malaysia, tobacco use accounts for massive 35% of in-hospital deaths, with 3 cancer, heart disease, stroke out of the country's 5 leading killer, accounting for a large share of these deaths. More than 10,000 Malaysians die from smoking related illness every year. How to diagnose oral cancer? Biopsy. that is, analysis of tissue taken from suspected pathology. Imaging, radiographic analysis of the part of the body related to the spread of pathology. This includes plain radiographs, CT scan, MRI, technetium bone scan, ultrasound. Chances of getting oral cancer can be reduced by stop or not smoking, avoid alcohol drinks, quit tobacco, chewing or betel nut, limiting exposure to the sun, have a regular dental checkup, do self-examination of your mouth, healthy lifestyle. These are the controlling measures for the cancer. Prevention and control of oral cancer, regulatory approach, service approach, and educational approach. Regulatory oral legal approach. As early as 1590, the government in Japan edict against tobacco use, where users were penalized by having their property confiscated or were jailed. Similar edicts have been reported in Turkey, Russia, and China. Religious groups have also banned the use of tobacco. In Malaysia, it's necessary to print warning on cigarette packets. BD are not being included for printing statutory warnings, ban on advertising tobacco products, and high tax. Service approach. Primary goal is a fundamental of prevention. This can be achieved enough screening and early detection. It also provides an opportunity to identify and counsel the patients about the habits that increase the risk of cancer. Other than professional primary healthcare workers can also be used for screening. Diagnostic methods such as biopsy technique, exfoliative cytology, toluidine blue vital staining can be used under this approach. Educational approach. The process of becoming a smoker, for example, essentially involves four stages. First is awareness, then initiation or experimentation, then habituation, then maintenance or dependence. So, education has an important part to play in discouraging people from starting its use and from helping people to stop the habit. Tobacco cessation. That includes stages of development of addiction. The initiation and development of tobacco use among children and adolescents progression stages. First is forming attitude and belief about tobacco. Trying a tobacco, experimenting with the tobacco, regular using tobacco, becoming addicted to tobacco. This process generally takes about 3 years. Guide to counseling for tobacco cessation, that is 5 A's: ask, advise, assess, assist, arrange. We will discuss about ask. Ask the patient about their use of tobacco at every visit. Check for oral signs of tobacco use, which are stained teeth, halitosis, periodontal disease, tooth mobility, etc. If asking the patient has shown that patient is consuming tobacco, then we have to advise him. Advise non-users to never use tobacco, encourage never users to stay away from tobacco, affirm and congratulate those who have reduced or quit the tobacco. Advice for quitting should be clear, strong, and personalized. Assess. Ask every tobacco user is willing to quit at this time or not. Assess the risk of relapse. An individual who has quit before, even for just 30 days, has lower risk of relapse. Assist. Assist with quitting. Set a firm quit date, ideally within 2 weeks. Set support from family, friends, and co-workers. Review past quit attempts, what helped or led to relapse. Arrange. Arrange for follow-ups. Use revisits, telephone contact, or assist the patient to arrange an appointment with his or her physician or trained community health workers, set a timing, actions during follow-up contact, assess the need for intensive counseling. Counseling, that is the 5R method, that is relevance of quitting based on personal reasons, feed patients with information, risk of continuing tobacco use, that is acute risk, long-term risk, environmental risk, reward of quitting, improved oral health, increased energy, food tastes better, money is saved, set good example, longer and healthier life. Roadblocks to quitting, fear of withdrawal symptoms, lack of support, enjoyment of tobacco, repetition, like to motivate patient, we have to repeat all these 4 R's again. Coming to levels of prevention. In this table, we can see there are 3 levels: primary, secondary, and tertiary level, and service provided by the individual. First, individual service provider, how we can prevent oral cancer. Under primary prevention, under health promotion, periodic visit to dental office, then demand for preventive services. Specific protection, avoidance of known irritants, like that we can prevent oral cancer. Second, under secondary, that is early diagnosis and prompt treatment, like self-examination, we have to examine ourselves. Then if you found something, we have to go visit dental clinic and utilize of dental services. In tertiary, that is disability limitation, utilization of dental services. In the tertiary, already cancer is in established stage, so we have to utilize dental services. In tertiary, there is rehabilitation. This is the worst case where already cancer is affected and you have gone for treatment, where reconstructive measures are needed. So that time you have to go for utilization of dental services. This is our individual thing, like our own responsibility. Then comes to service provided by dental community. Under primary, health promotion, dental health education, promotion of research efforts, and other lobby efforts. That is political lobbies. Then specific protection, avoidance of known irritants. Under secondary, that is early diagnosis and prompt treatment, periodic screening, that is primary thing from the community providers. Then provision of dental services. Under tertiary, that is disability limitation, provision of dental services. We have to provide some things who are affected with cancer for them. Then rehabilitation, it's same, but this in the tertiary, disability limitation and rehabilitation are both are provision of dental services. Then comes to service provided by dental professionals. Primary, health promotion, patient education, specific protection, removal of non-irritants. In secondary, early diagnosis and prompt treatment, there is complete examination, biopsy, complete excision. Then tertiary, disability limitation, that is chemotherapy, radiotherapy, and surgery. Then rehabilitation, maxillofacial and removable prosthodontics, plastic surgery, and speech therapy. So these are advanced treatment. Public health strategies of Ministry of Health Malaysia in prevention and control of oral tobacco control in Malaysia. In 1983, the Ministry of Health Malaysia, in collaboration with the Malaysian Medical Association, carried out the country's first major anti-tobacco effort. A workshop on smoking and health was followed by the launch of nationwide No Smoking Day campaign. The first national level World No Tobacco Day in Malaysia was celebrated in 1993 when the Prime Minister's wife launched the theme Health Service, our window to a tobacco-free world. Current initiatives in tobacco control, like legislation, enforcement activities, anti-tobacco promotion, smoking cessation services, tobacco taxation. History. In 1973, smoking is banned in cinemas. In 1975, Ministry of Health and Ministry of Defense banned smoking in all of their hospital, clinics, and health centers. In 1977, health warning, Morakak Membiahakan Kesihatan. Please forgive me if I am pronouncing wrongly. And cigarettes packs and advertisements is made mandatory. Magazines are exempted from this requirement. In 1980, World Health Theme Smoking or Health. In 1981, smoking banned on air-conditioned train coaches and in buses. In 1982, cigarette advertisement banned. In 1986, No Smoking Day campaign. In 1987, No Smoking Week. 1988, 5% increase in tobacco tax. 1992, 100% increase in tobacco tax. 93, Gazetted of Control of Tobacco Product Regulation. 94, tobacco legislation comes into force. 1995, National Fatwa Council rules smoking to be haram. Then 1996, smoking is banned on all domestic flights. 2000, smoking is banned on all international flights. In 2019, smokers were banned from smoking at restaurant and food premises. Other activities: training dentist role in smoking cessation, ongoing training targeting all Ministry of Health dentists. Mouth Cancer Awareness Week, second week of November, yearly since 2006. There is free screening campaign against smoking and tobacco use, health education, promotion of the health, then mouth cancer awareness walk. Issues and challenges: low uptake of the screening program, low compliance of referral, late diagnosis and treatment, patient failed to come for screening, diagnosis and logistic, services like late referral, most cases were detected at late stage, more than 60% of the cases seen by the surgeon are pre-malignant and malignant lesions. 20.7% detected at stage 1, 60% detected at stage 3 and 4. Effectiveness of health education and promotion activities related to oral cancer and risk habits. Public awareness on oral cancer. There is no shot 20. National Oral Health Plan for Malaysia in 2011 and 2020. Tobacco use is a risk factor for development of periodontal disease and oral cancer. Smoking prevalence is high, that's 21.5% in Malaysian population, with 46.4% of males being smokers. About 9%, that is 8.7% of adolescents, that is 13 to greater than 18 year, are already smokers. Tobacco use and other risk habits like betel quid, chewing gum, and excessive alcohol consumption that are the certain prevalent in certain communities. Late detection of oral cancers contribute to high disease burden, morbidity, and mortality in affected individuals and is also an area of concern. Only 26% were detected at stage. National Oral Health Plan for Malaysia 2011-2020 recommendation. To combat the predicted sharp increase in new cancer cases, it is essential to embark on planning and implementation of effective cancer control strategies, such as reducing tobacco use and alcohol consumption, promoting healthy lifestyle and diet, performing early detection through screening and mouth self examination, as well as pushing for greater awareness on risk habits for oral malignancies. Role of cancer registry to reduce the incidence, morbidity, and mortality of the cancer, to improve the quality of life of cancer patients through the systematic implementation of evidence based interventions in prevention, early diagnosis, treatment, and palliative care. National Cancer Control Program, that is NCCP, has a cancer surveillance program built around a population based cancer registry. It is essential in monitoring the progress of the implementation of an NCCP, evaluation of individual cancer controlling activity, then cancer surveillance program should provide statistical data on incidence, mortality, and stage distribution, treatment patterns, and survival. Thank you.